Hello everyone and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at Foley & Lardner. Just a few housekeeping items to go over. We would like to remind everyone that the Q&A feature will be available, so feel free to send in those questions for the panelists throughout the discussion. Afterwards, join us for yoga led by instructor Stephanie Wallace. And with that, I'll throw it over to our moderator who joins us from Foley & Lardner, Christopher Donovan.
Thank you, Debrell, and welcome to today's webcast on AI expansion in the healthcare landscape. My name is Chris Donovan. I'm the co-chair of the healthcare industry team at Foley & Lardner, and I'm delighted to have everybody here today. We have a terrific panel of speakers. The format, as Debrell mentioned today, is we're going to have some brief introductions, and anybody wants to ask a question, you can just hit the question toggle at the bottom toolbar there and probably answer those sort of halfway through and then at the end to keep things kind of running smoothly. But in terms of the agenda, I wrote down sort of 3 words today. I think that will guide our discussion: integration, perspectives, and opportunities. We're going to talk a little bit today about some of the real live cases that I think AI is being used in healthcare from a clinical standpoint as opposed to theoretical. We're going to have perspectives from both the payer community, the provider community, and the technology community, which I think will create an interesting discussion, hopefully for everyone. And then finally, some of the opportunities and perhaps some of the challenges that are out there for all parties to the AI healthcare landscape that we will address. So we've got a terrific panel: Ashima Gupta, the Director of Global Healthcare Solutions at Google Cloud; John Halamka, my fellow Bostonian here, the President of the Mayo Clinic platform; and Sanji Fernando, VP of AI and Analytics Platforms at Optum. So before we get into the meat of it, I'm just going to ask each of them to make a brief introduction of themselves and what they do, and then we'll get into the agenda. Ashima, would you like to take it?
Thank you, Christopher. Hi, this is Ashima Gupta. I lead our healthcare provider strategy for Google Cloud. That includes driving strategy, product roadmap, and go-to-market for the industry. Thank you for listening in. I'm excited to talk about how we at Google Cloud are thinking about bringing AI to the world of healthcare. By way of introduction, I'm also ex-Kaiser Permanente, so I come from the industry and now in big tech, so happy to be here. Thank you, Christopher.
John?
Hey, John Halamka, President of Mayo Clinic Platform, emergency physician, as well as former CIO at Beth Israel Deaconess and Harvard Medical School. And my role at Mayo is overseeing all the digital businesses worldwide and asking the question, how do you ethically use the data of the past and algorithms and virtual care to deliver advanced cures, safety, and quality in a democratized way going forward?
Thank you, John. Sanji?
Yeah, thanks to everyone. I'm Sanji Fernando. I'm responsible for AI and analytic platforms at Optum. Optum is a very well diversified healthcare business, and you might think of us more classically as a payer because of our sister company, United Healthcare, but we're also one of the largest providers in the US today. And my team is responsible for designing and training new AI solutions, primarily in the administrative space, but also we're exploring ways we could support clinical decisioning. And the underlying platforms allow us to do that quickly using cloud tools from Microsoft and Google.
Fantastic. Thank you, Sanji. Thank you, everybody. Maybe you just start this off, maybe an inappropriate metaphor since baseball isn't really in full swing if you look at the current state of play, but where are we with AI right now in healthcare? Are we in the early innings, the mid innings, the late innings? Are there bigger challenges or bigger opportunities? Kind of an open-ended question. Where are we in the overall landscape? Ashima, can I start with you and we can rotate over to John or Sanji, or whichever order y'all want to take it on is fine with me as well.
We always defer to Ashima.
I think this is what happens when your name starts with A.
Starts with an A.
I'm here 2 ways. No, absolutely. I think from the AI perspective, I think the good news is the complexity and the rise of data in healthcare means that artificial intelligence will always have increased applicability for the field. and several types of AI are already deployed in the both payers, provider, and life sciences companies. Where I sit, I see incredible use cases. And a recent study by McKinsey's Global Institute says companies that fully absorb AI in their value-producing workflows by 2025 will dominate the 2030 world economy with plus 120% cash flow growth. So this is true not just for healthcare, but for many different industries. Healthcare specific, I still believe we are in very early days. The applicability that we see a lot in clinical decision support to assisting physicians, clinicians in their decision-making process for patient treatment. That's one of the use cases. We recently announced our work with DIU, which is a defense innovation unit in DoD, for diagnosis of 4 different types of cancers based on the pathology images through an augmented reality microscope for these 4 different types of cancers. But still, they're pretty early days. It's still a prototype. I think when we talk about AI, I think where I see the challenge is taking the model from a research and prototype to really bringing it to the clinical practice. That is definitely taking a lot longer than expected. I think that's where the opportunity lies, where machine learning model is not enough. How do you take that machine learning model and bring it into a clinical practice? I think that's where some of the challenge lies. The second part, I said there's a new area emerging called machine learning ops. Like we did DevOps in the early days of bringing developer and operational things together, deploying machine learning is still hard. And this machine learning ops is a brand new area that we are investing heavily in. And how do you take the model and make sure you're able to experiment, make sure you're able to test not just the code, but the data. And that is an opportunity and a challenge, whatever you want to call it, is to really make machine learning easy in the enterprise setting. You need these new practices that are emerging. John, I'll hand it over to you. I think when we talk about machine learning ops, I know the AI factory work that Mayo is doing, so kind of good segue there.
Perfect. So Ashima really framed it up well. I think William Gibson told us all the future is already here, it's just unevenly distributed. So does Mayo have production systems in clinical use today based on algorithms that we've developed using TensorFlow? Absolutely, right? Already there, already being used every day. In fact, a few months ago, just for fun, I had a 12-lead ECG so that it would automatically be processed through an AI dashboard and give me some lifetime risks for atrial fibrillation, hypertrophic cardiomyopathy, pulmonary hypertension, and predict my ejection fraction, all using live in production AI models. So it's there. But Ashima, both highlights the difficulty in going from idea to algorithm and then algorithm to production. So next Wednesday, Google and Mayo go live with the AI Factory. And what the AI Factory is 154 years of Mayo's de-identified data made available to all Mayo investigators with a set of tools so that you can use historical data as well as bring your own data. It might be novel telemetry or a registry into an environment and then run AI models, while also having a center of excellence that at your elbow helps you understand how to develop models, how to validate models, really what questions you can ask of the data. And then we continue to work together, and the Google team and Mayo team have this joint activity to figure out how to, at scale, deploy the production AI models and democratize them. So our notion is, let's build the tooling, let's build the platform, let's make sure our algorithms and others' algorithms get out there and get them more evenly distributed.
Yeah, I think from Optum's standpoint, I think some of the clinical breakthroughs are absolutely going to happen. Mm-hmm. And if I use the baseball metaphor, we might be in the early innings, but we've got some runs on the board and we got men on first and third. And I say that because our focus has also been on the administrative side of healthcare. We have so many important administrative processes like revenue cycle management, risk and quality, risk adjustment, utilization management, and prior authorization. And for those administrative processes, we found that some of the more recent breakthroughs in AI that are sparking all this conversation, predominantly neural networks and deep learning neural networks, had this great ability for us to train on some of these administrative tasks. And that's what we've been going to production with. We've been actually transforming key business operations by training models to almost pre-screen a medical chart to decide if it needs a third-party review for reimbursement levels. Pre-screen charts to decide if a medical coder really needs to open it up and is going to find a difference in risk adjustment from what the claims history represents. Those are models that we're putting in production today, and I tell friends and family, like, it's patently unsexy, but we are using some pretty cool model architectures like CNNs on natural language, where we're training BERT models to accomplish all this. And while we may not be in production with some of the clinical decision use cases that we'd like to see and hear a lot about, these administrative use cases are incredibly important, incredibly impactful, and play a small or big part in helping us bend the cost curve for U.S. healthcare.
Thank you,
And you bring up a good point. I think that we are seeing that automation and efficiency, especially when we look and work with a lot of providers, that a lot of like COVID has caused the already thin operating margins to some of the stats are they're losing $50 billion per month. And then that necessitates, what can we bring the operation efficiency? What can we automate from the back end perspective? So definitely a lot of use cases there in addition to the clinical ones.
Yeah, I think there's a margin challenge. There's also, as you guys have both alluded to, an explosion of information and data for us to help make very complicated decisions, maybe more so than we've ever had at any point in time. And we need better tools to help us find those things that are so important for people to understand, the most complex cases, so that they're working to their full license. But some of the rote things we should try to automate, and we should try to make easier, more efficient, less costly to do. And I think that's been a lot of our focus, and it's going to keep us busy for a long time. There's my boss, my old boss at Optum Labs is this guy, Dr. Paul Blecher, and he uses a great analogy of autopilots when he talks about AI. Like, when autopilots came to be in transatlantic flights, it was a great breakthrough, but it didn't eliminate the need for a pilot. It just recognized that a pilot didn't need to have their hand on the stick for the thousands of miles across the Atlantic Ocean. But at those critical points in time when you're taking off or landing, they could be operating at their full license. And I think that's a perspective and a metaphor that we think about a lot at Optum. What are the things that we can, put into software, put into machine learning algorithms, so the people that do need to work on a lot of the complexity in at least our U.S. healthcare system and our global healthcare, they could focus on that and maybe free them up for that complexity.
Just looking at the, go ahead, John. Look like you're about to say.
Well, I was going to say, maybe one last thing to add is that in this time of COVID, we've not only had technology change and policy change, regulatory waivers and reimbursement changes, we've had a cultural expectation change. So I can see you're in your Foley and Lardner offices. Oh, no, you're not. You're actually in your apartment with a background. Why? Because we all are changing our workflow and our life experience to be more virtual. Well, if we're going to want expert specialty care in a virtual environment at a distance, we're going to need new tooling.
One question, there are a bunch of questions that have been asked. We're up to a pretty high number, but just listening to everybody, when I think of AI, and I think, a couple of the titles here about predictive analytics, it's designed, at least on the clinical side, to provide clinicians with, let's just say, some guidance in terms of a proper diagnosis or plan of care. One of the questions that I was just noticing here, it says AI is only as good as the number of times it can learn from interactions in healthcare. So where is the best fit for consumers? So I'm just throwing it out there. Do any of the AI tools that you all are using have sort of retrospective reviews in terms of their effectiveness in terms of their predictive capabilities in clinical settings? And how is that information captured to make AI the most effective in the best settings or the best fit? I think that's what the question's asking.
Well, why don't I just start with the way Mayo Clinic validates these things, right? So you have a training set and then you have a validation set. So when you publish the paper, it actually looks to say, well, how well did it do on newly presented data? And that's what we say is the AUC, right? Okay, it's got an AUC of 0.9, it's pretty good, right? And therefore it's sort of sufficient for purpose. And the other question that was just asked about, well, how do you use AI in a clinically meaningful way using the encounters of the past to inform care of the future? I'm going to give you the craziest example ever, which Ashma may have heard. I was called a couple of years ago to consult on a case of a patient who showed up in an emergency department in Bakersfield. 24-year-old woman found running naked through a Walmart parking lot at 3 in the morning. The emergency physician examined her, did a toxicology screen, found cannabis, and said, well, of course, cannabis explains this radical change in her behavior. Well, if an AI model looked at every 24-year-old who'd ever consumed cannabis and the probability they would be running naked through a Walmart parking lot at 3 in the morning, that model would say, not the cannabis. She was discharged home. She was luckily then seen in Boston. We evaluated her and found the worst case of meningitis that you had ever seen. It had nothing to do with the cannabis whatsoever. And so that's where we're not saying AI replaces human decision-making, but it certainly can give you the realm of the possibilities to augment your decision-making.
Yeah, I think the
Yeah,
focus.
there's one thing I wanted to add, like, because Asham brought up ML ops, and said, you, John, like, that's another piece of this too, like, at least what we found is that training the model, validating against a data set to see if it works appropriately is almost like the starting point, not the finish line for these models in production. A lot of our investments in ML ops are about looking at data that might be coming into the model, that might be drifting, retraining different model architectures in the background to see if we could improve those AUC values or the precision recall of the models, depending on what we're trying to optimize for. And so I think that's another big piece of it, is that you need these capabilities to do that at scale, to do it well, because it's almost like the finish line is not a completed model, it's almost the starting point.
And I would add to that, Sanjay, that it's not easy right now, I'll be the first to admit, and that's why we're seeing a lot of AI models being built. But these are all great questions. To bring them to clinical practice, you need this kind of machine learning ops or a system, because we have, especially machine learning and AI, they have a special capacity for creating technical debt if you don't manage it well. And they all have maintenance problems that Dr. Hlamka was mentioning, like the data around the models are changing. There's in a normal software development in computer science, you're testing the code, the regression testing of the code. Here it's not just the code, it's the data. Is the model learning from the new set of data that is coming in? Especially true in light of COVID. We are now seeing the data never seen before. So a model has to be constantly updated, constantly learn from the data, and also go back to, okay, what was, when the model was built, what was the production based on this input values? That entire machine learning development life cycle is yet to be fully built at the scale like where DevOps reached, and it took us, I believe, like 5 to 10 years to get to that maturity with DevOps. And in machine learning, it's still early days, and this machine learning ops will get us to like automating of the entire construction of machine learning system, including integration, testing, and understanding the complexities of care delivery, right? Even when we build the model, we have it fully operationalized, and bringing it to the clinical workflow is hard, right? And an assistant, are you seeing side by side the results of a model in how is it assisting the radiologist or a pathologist? So not just focusing on a model, but the outcome that is about to deliver. I think how to measure that.
If I could just, I'm looking at a lot of the questions here, and I can see a kind of a thread here. And one of the threads, and we've been reading about this on the legal front too, is the acceptance of AI by clinicians and the use or non-use of AI by clinicians. When is it acceptable for a physician, for example, to rely on AI? When is it not acceptable and potentially, exposing the physician to liability for ignoring AI, and, patient choice? And I guess a question for the panel is how much of what we're talking about in AI is one of the bottlenecks is getting clinician acceptance or the appropriate use of AI in the appropriate context. And are there barriers to that? And are they cultural? Maybe throw that to you, John, because you're a doctor. You can kind of kick us off.
Well, sure. So as an emergency physician, what is malpractice? Is malpractice that I made a mistake and a bad outcome happened? No. Malpractice is that I violated the community standard of care, right? I did something that was just so unusual that it wouldn't be expected. Well, what does AI do for us? It says, oh, well, here's 1 million patients of the past, and based on these signs and symptoms, geography, timing, scenario, genomics, whatever, here is what we would think would be a community standard, a probability of a course going forward. So the great thing about AI is in many ways, it could be quite easy to say, look, I have an algorithm which was highly repeatable and well-tested that offered me, not again a diagnosis or treatment, but told me about the community standard going forward. So that's good. But let me answer another way. So Sanji, do you ever work with doctors who are using electronic health records? Or Ashima at Kaiser, how about that? They are just loving every minute of it, right? No.
All read at the fingertips. No, absolutely far from it, Dr. Lampkin. I think you touched on the right point.
And so what if an AI tool would say, oh, well, I can help you autocomplete your chart. I can help you enhance your documentation appropriately. I can tell you what's missing from your documentation. Doctors are screaming for workflow automation and burden reduction driven by AI.
And I can tell you a Kaiser example, Dr. Halamka. We were building the diabetes management, and I was super proud of it, bringing all the glucose meter data, reading, activity, nutrition. And it was not very well received because physicians today face an overwhelming volume of data. And bringing just more data and not the insights, I think we are then adding to their workload. So from the adoption perspective, wearing a physician hat, can you assist them? Can you make their lives better? Can you aid them with like some productivity gains? I think that's where physicians are much more open to it. And the second is there was a few years ago, there was some narrative that AI is going to replace physicians. So there's that, I think we're all kind of getting back to it's an assisting technology. It's not a replacement. There were a lot of claims being made, and that led to some kind of angst towards AI, but it is a wide recognition now that AI is there to assist humans. There's a lot of overwhelming amount of data for physicians and misdiagnosis. When you talk about radiology, pathology, it's a critical issue in US healthcare. We are impacting 12 million patients each year. Can we fix that? Can AI be of assistance in looking at the shoulder of the doctor and providing them the cues? I think that's where we will see the physician adoption as an assistant versus the kind of replacement.
Yeah, I mean, I think everything has been said appropriately. Like, I think AMA, I might have been wrong, called it augmented intelligence. And I think that might be what physicians are really looking for, to unburden them of this overwhelming tidal of information. And maybe at a minimum, just being able to know who's the most important, almost like a triage, who should I be looking at? You know, maybe even without assistance on what I should do from a care plan or from a differential diagnosis, just simply knowing who's out there that I should be keeping my eye on. Because it's hard. I can imagine it's overwhelming, the amount of information, the amount of workflow steps we've introduced that burden the physician today.
Anybody, one thing I want to maybe discuss, are there particular applications, John, you mentioned a couple in the emergency room context, but Are there any particular applications that anybody's working on now in the AI clinical? I appreciate, Sanji, you're focused a little bit on the payment side, but well, either on the payment or on the clinical side. Are there particular applications that you've seen that are really advanced much more successfully and much more quickly than others over the AI landscape?
So I'll start with just a couple of quick examples. The challenge is, as doctors are already overwhelmed, as we talked about, separating signal from noise is really challenging, and especially when you look at new sensors, telemetry. What if you had your Apple Watch sending us your lead 1 ECG every 5 minutes? I go, what are you going to do with that? So the Department of Cardiology at Mayo has for several years worked on algorithms that will evaluate ECG and other cardiac telemetry to identify variation that's meaningful, to predict events that require an intervention. And so that's all in production, as I mentioned, and there are many new algorithms already in process. Neurology is working on an algorithm to leverage clinical expertise and scale it across the world. What if an expert neurologist can diagnose Parkinsonism or, say, ALS, Lou Gehrig's disease, by listening to you speak? Because it's your timbre, your tone, your cadence. It's not so much what you say, it's how you say it. Well, scaling that across the world, because it's just an expert, pretty hard. But what if you train an algorithm that looks for the variation that that expert hears? And then that algorithm's a chatbot. And you can just speak to the chatbot and get at least a probability of a neuromuscular disorder. We're working on that. And then in collaboration with Google, we're working on a really exciting project to deliver radiation therapy, programming the linear accelerators of the world at a distance by taking images of tumors, AI algorithms, and then figuring out how to best deliver radiation to them. So all of these are either in production or will be in production shortly. And this is absolutely a signal noise filtering approach that clinicians across the world are really begging for.
And Dr. Halamka, to your point, right, when we talk about radiotherapy, I think the focus is, can we help radiologists by creating the contour that the machine learning algorithm, based on its learning from the similar images, is able to contour now. If you do that manual, it takes days. Can an AI algorithm can help contour the tumor so your treatment can be given and can be more precise? So that from the clinical side, I think more humble use cases that I've personally seen come up is during COVID, the whole chatbot that Dr. Halamka just touched on. The chatbot or the conversational agents became the tool as a digital front door and digital strong touch points. These are multilingual, conversational-based, AI-based agents. And as patients struggled, like in the call centers were overwhelmed, like the average wait time peaked for 30, 40 minutes. This was early days of the pandemic. So now how do you guide that, the triage, I call it intelligent patient triage, based on the CDC guidelines, where do you direct the patients? We all talk about right care, right time, right setting, but that's a lot of like a traffic control monitoring and then understanding the symptoms and being able to converse in multiple different languages. And that chatbot were spun up like over in the matter of weeks, and they became the digital contact point in helping and directing people with, for example, less serious symptoms to relevant self-care options, to when the symptoms are more severe, directing them to, maybe the high risk and high acuity patients to a different setting. And that was pretty inspiring to see that in healthcare, chat was more kind of an afterthought, and that became the frontline digital front door point of contact. I think that was pretty telling.
Yeah, one thing I could just add is, like, as I look at AI and I'm going to say something a little bit controversial, like training and building the models is sort of the easy part sometimes, given all the amazing open source contributions from academics, from companies like Google and Facebook. There's a big change management challenge to get something over the finish line, not finish line, but get into production and get it to be used and implemented by people. As I reflect on some of the things that we've done that have gotten to production that have been successful, there's a pattern in there that is starting to emerge where, again, this is more administrative, but if we can figure out those instances where the model can agree with both counterparties, like the payer and the provider, that they agree that this utilization is needed, or this claim should be paid at the amount proposed. If we get to yes, those use cases are easy to automate in software. If there's trust and understanding in the model that can negotiate that getting to yes, those are the things like that. When I think about use cases that we've implemented in revenue cycle management and risk adjustment, even utilization management, that's where we've had success, where everyone agrees, and we can not rely on maybe millions of rules to figure out that agreement, but we can train from previous examples and get to yes. I think that's a pattern forward. And if you could find that in your business and your use cases, that might be a way to get over some of the change management hurdles that we face around AI.
Ashma, I think you're on mute.
Sorry. I was going to say, Sanjay, to your point, I think as we look into the future, right, we all experience that firsthand, both as a consumer or a technologist or from the healthcare systems perspective. We're all geared to handle linear incremental demand on our health systems. While the virus, it grows at the exponential speed, right? So how do you match and address that? And as you're looking into post-pandemic world, the possible wave of postponed and deferred care that will may impact now health systems as patients start to resume those services. Can we help predict, forecast, and personalize those options from the patient's perspective? I think that's where we would see that AI will again become in the forefront in helping with that, the possible, when the postponed procedure, the deferred care, it still needs to be addressed. Those cancer patients that didn't see their oncologists, they need to come back to the facility, and there's that pent-up demand. And then yet we do not know from the pandemic perspective, how will we handle that capacity, right? So more use cases to emerge there, I think, is the need for the hour now to be we cannot be as nimble or exponential in both building the capacity and bringing it down, like as was seen before, but something needs to be addressed there.
Thank you, Ashma. One thing, we've got quite a few questions here, and I'm just trying to figure one of the threads that I'm seeing here is maybe just shifting over from the opportunity side to the headwind side. Barriers to further evolution of AI, incorporation of it into the payment and clinical sides. The FDA has come out with software as a medical device, and the 21st Centuries Act, et cetera, attempting to exclude a lot of the algorithms from regulation, depending upon if a physician can sort of independently make a clinical judgment on the basis of the algorithm's recommendation, et cetera. There's other articles in the literature, at least we're seeing in the legal area, of product liability claims vis-a-vis software tech companies. Patient choice, do patients need to be informed of this, should be part of patient consent. This whole area is really, a very fluid situation right now. So I don't want to get into a legal analysis of this, because I think the comments from the panel here on what's happening in their business is more interesting to the audience. But I do want to kind of pull together 5 or 6 questions here that are kind of going in that area of regulation, patient choice, liability stuff, without, as I said, getting into any kind of hard legal analysis. But I'm just wondering, in connection with your businesses, what kind of issues you've seen in that space, what kind of sensitivities you have to it, whether you view those as obstacles or, maybe not. So
why don't I start with 2 issues?
Yeah.
So first is data quality. So imagine, I'm going to make this up, Chris, this couldn't possibly happen, that some dude decides to assemble a whole bunch of data from places with poor provenance, who knows where it came from, and produce an AI model that says hydroxychloroquine is really bad, and the entire world changes their prescribing pattern. Well, wait a minute. As a society, how did we let that happen? Because if you feed an AI model with data of questionable quality, it is highly likely you're going to get an unpredictable result. And so ensuring that you have curated data of known provenance, what questions you're really able to ask of it, what is going to produce a meaningful model, that's absolutely key. And then you ask a really important question. What is the ethical and privacy protecting use of the data you gather in the creation of algorithms? Because sure, we have HIPAA, GDPR, California Consumer Privacy Act, but we also have culture. And if I said, Chris, you know, I'm going to use all the data you just gave me to create an algorithm so I can go buy a yacht. Well, that doesn't sound right. If I told you I'm going to use all your data in an anonymized, aggregated way so that people like you can get cured faster and we can spread it to the areas of the world that have no cures today, you'd say, wow, you know, that actually sounds pretty good, right? So what we need is a framework for the ethical use of data, and of course, incorporating into that, you know, what kind of consent do you need for what?
Yeah, and I think one thing to add there, Dr. Halamka, is the tools like de-identification. When we talk about like patients and their data, so our recent work with Defense Innovation Unit on the augmented reality microscope for the pathology, that model was built on de-identified data sets. So when you have, but that tooling is relatively new, like de-identification of data, privacy of data, and it will become the table stakes, and it has become the table stakes. Like privacy preserving is the word Dr. Halamka uses a lot, and I'm trying to, you know, bring that into the forefront of every conversation. That from the patient perspective, privacy is critical, and that's the first table stake. Can we help de-identify the data sets and then build a model? There's a lot of learning that can be had from seeing a pattern in the wide swaths of data and in identifying and building that machine learning model.
Yeah, the only thing I'd add is, like, we think a lot about the ethical use of AI, and this might be a broad statement, but maybe a challenge to this audience too. Like, you know, Mark Andrews has said 8 years ago that software is eating the world, and maybe true, maybe not, AI might eat healthcare. And if that's the case, I think we all owe it to ourselves to understand how data is used in training models, how it's used in both, you know, some of these neural net derived solutions, maybe probabilistic solutions, as well as how outputs from models are right and wrong. You know, I don't think everyone needs to know how a confusion matrix works, but the basics of it, we probably all need to learn a little bit more. And I think if we all, you know, sort of embrace the understanding of how these technological changes may transform our industry, I think we'll all have an important stake in understanding how they should be appropriately used and when they can be used inappropriately. And so, you know, it's maybe a call to action for all of us to recognize that this may be a big part of our lives going forward over the next decade. And we just need to understand it more than we might today.
Yeah. I think at the end of the day, from healthcare's perspective, one of the greatest enemy or hindrance is not the overhyped technology or overhyped promises. I think it's sometimes the organization inertia, if you will. If we believe there's a promise of AI in applying that into a clinical setting or into the back-end automation to help augment the human productivity, and I think we will find a way. And I think that's a call to action, as Sanjay said, to all of us to find a way. And we all have a tendency to sometimes to wait, and that makes sense. But in a world that we are experiencing rapid, significant, lasting change brought in by this pandemic, you know, doing nothing kind of, I'm not saying that people are not doing much, but this is the right time to do it. Can we co-create the future as we are all experiencing this change in such a profound way in our lives, both as either a technologist enabling or as a consumer or a patient, or taking care of our loved ones. So we absolutely need human ingenuity and talent, and focusing on the highest value of work and promise of AI. I think that's what I would leave it at.
Thank you, Ashima. One of the things, again, just dipping it back into the question pool, which is deep. One of them reads, social determinants of health are key, yet still rhetoric instead of reality. Do you see healthcare payers and systems leveraging AI in these dimensions in combination with more traditional healthcare? And I can tell you from here at Foley, you know, we are definitely, some of it spawned by the pandemic, particularly in certain areas like behavioral health, telemedicine, other areas where algorithms are being developed to treat people remotely who previously weren't, you know, getting the care they needed, particularly in behavioral health, which I think, frankly, used to be a stigmatized area and is no longer in that area. But just sort of more broadly in terms of social determinants of health and AI, this does seem to be an area where AI can really make some impacts, reducing costs and enhancing outcomes. And I'm just wondering if in any of your experiences you've seen the intersection of social determinants of health and AI and what your perspectives on it are.
Let me give you two perspectives on that. So the first is gathering the data for social determinants of health with any degree of fidelity is challenging. And there are startup companies today, and I'm not mentioning any specific company or endorsing any service, but the Kaiser, for example, outsourced social determinants of health management to a company that specializes in going to the home, figuring out, are you in a food desert? You know, what's your access to childcare and transportation? Because it wasn't in the medical record. And what Kaiser recognized is, gee, you've had 12 emergency department visits this year. Actually, it would be cheaper to make sure that you had an apartment. And so we're starting to see that, yeah, we got to take a deeper look at what are the true social determinants of health, gathering and curating that data. There's another element to this, and that is ensuring that our AI algorithms don't have bias. Because, you know, and again, I just will mention this, but what if you developed an AI algorithm based on just the population of Rochester, Minnesota? Well, chances are that algorithm would not be generally applicable to all places in the US. So you start to have to ask questions, you know, what are the nature of the numbers of patients and their geographies and their heterogeneity that are necessary to produce an algorithm which is generally applicable? And so looking back on pre-developed algorithms to look for bias in those algorithms and then redoing them would be important.
Sanji, Ashna?
You know, I think from the data perspective, I think that's where the empathy towards our buyers come in. Like from the provider payer perspective, there is just so much data. How do you bring it to perspective from the patient's perspective? It's easier said than done. When we talk about patient centricity, that connecting the dots from the patient's perspective, a lot of times that data is not even available or not brought to the point of care. As Dr. Lamka mentioned, from Kaiser, we had to send people home to see whether you're living in the food desert. Do you have a safe housing? Are you looking into, so a lot of your health, as we say, the zip code is a good determinant of how healthy you would be. But these are the brand new data modalities from the enterprise perspective. How do you bring that data in a meaningful way? I think that remains still a big challenge. And we believe cloud tooling in analyzing the data can help, but that's from the tooling perspective, the building blocks perspective. When we look into, when I talk about shifting gears a little bit, building blocks like computer vision, NLP, and ability to look through the data and find those signals, you absolutely need technologies like artificial intelligence, especially in the field of natural language processing, because your data is scattered across multiple different systems. And when you look from like, just from the EHR perspective from 2009, now 90% of US uses some form of EHRs. We have wealth of digital information available for the patients, available today, digitized in the EHRs. Now, how much of that is being used? Because a lot of information is entered in clinical notes, right? This is a free form, free text data. This is not in one particular field. How do you even scan that? Maybe the patient, when they talk to the physician, they did talk about the food insecurities, right? But that there's no field in the EHR says, I have food insecurity. it is somewhere maybe in the notes, right? How do you scan that wealth of information today that is available in understanding those entities and getting that understanding from the patients? I think that's where I strongly believe there's a role for AI and machine learning to play in terms of getting the insights from the data we already have, and then going outside the org boundaries and getting this new set of data sets.
Yeah, the only thing I add, I think Dr. Hampa nailed it. Like, the data to represent social determinants of healthcare has a range of fidelity, and I know, regardless of AI, it is we've been leveraging that data to understand what's happening with our members, what's happening with our providers, what's happening with patients, and try to understand a fuller picture beyond classic health data, claims, and clinical data. The other piece of it is that, fairness is an incredibly important issue, especially when we're learning from data that, in some circumstances, academics have made a strong case that our system itself is biased. And so when you're learning from the ins and outs of a system that could be at risk, we've tried to implement tools. If someone has it, they should tell me, but I haven't found a tool that fixes bias in models per se, but a lot of the tooling right now is really important that helps us understand where bias may be generated and reflected in our output of the models. And if data like race and gender are overweighted in a way to reach that output, we should be aware of that. We should have a conversation about, we should understand why that's happening. In some cases, maybe clinically or some other reasons, it might be very valid, but there should be transparency and understanding of where that happens. And the one thing I think I'd just maybe plug is that you may believe your model is unbiased because you're not using those features like race and gender or other protected classes. But if you're learning from experiences or previous retrospective data that may inherently have a bias, you should look and see if your output class distribution is overweighted to a certain protected class or unprotected class. Just simply assuming that you don't use that information as featured for your model may not be a way to think that you're bias-free.
I just had a question. It's not on the question list here, but just sort of taking it outside the United States for a second. In listening to the conversation, we don't have a single payer system, obviously, here in the U.S. A little more complicated than the U.K., Canada, and other places. And to some extent, looking at the success other countries have had with fighting the COVID pandemic, where they do have a single payer system. I'm just wondering, are there any lessons to be learned? And this may be an unfair question to ask anybody on the panel, so there's no shame if there's no answer here. But are there lessons to be learned from outside the United States to the proper deployment of AI, maybe on the backs of some of the pandemic policies that have evolved in other countries and some of the successes, or take Sweden, lack of successes, other countries have had outside of the AI area. So I'm just sort of, bringing the conversation up a little bit higher, because you do get the feel that there is a lot of momentum with AI, but, whether it's, the XYZ health system or the XYZ payer system or this system, everybody's kind of looking at this sort of in their own particular way. And some of the larger systems, as one of the questions points out, have significant advantages because of the sheer size of the system, and the number of patients being treated. But are there examples outside the US or in other locations that we could learn from and say, this is really something we should think about that should really accelerate AI, and make it shareable and make it a little more democratic?
Yeah,
Let me start with please go ahead, Ashma.
Well, I had just one line to say, and then you can take it away. Christopher, I was going to say, it's not that they're led with AI, they're led with science, and they're led with data. I think that is a lesson learned. It's when you're in a situation like pandemic, leading with science is important, right? It's not just about a application of AI, and that belief in data-driven decision-making and leading with science was, I believe, what led better outcomes in different countries than here. But Dr. Lamka.
So let me just give you two quick examples. Most countries in the world have a, well, call, if it's not a national healthcare identifier, they have a nationwide patient matching strategy. And what that means is you can bring a longitudinal record of the patient experience, inpatient, outpatient, skilled nursing facility, surgery, together so one can ask questions about, oh, when they had this intervention, what was their outcome? You can answer, as sort of Ashima suggested, the science questions better when you can unify patient data across disparate locations and episodes of care. Lots of work being done in the US, some startup companies, academics working on this notion. It is unlikely that we're going to have a single national identifier for healthcare anytime soon, but it is possible that we'll have algorithms that help us bring patient data together from disparate sources better than happens today. So that's one thing we could certainly learn. The other thing is, and again, I'm just going to give you something factual. I co-lead the COVID-19 Healthcare Coalition, of which Optum and Google are members. 1,200 companies working together for purely to benefit society. We wanted to ask questions like, well, oh, what is the efficacy of convalescent plasma? How is telemedicine impacting healthcare quality? Well, here's what we had to do. It's not a criticism, it's just the reality of what we had to do. We went to the EHR vendors who are extraordinarily collaborative and said, well, you know, EHR vendors don't actually control their customers' data. So if what you wanted was the data from this health system or that health system, the health system itself would have to provide it to you. So the EHR vendors wrote scripts in 2,400 separate institutions, which then CIOs ran individually and then FTP'd to a central data location in a de-identified way securely so the analysis could be done. I mean, it worked. But is that the way you would architect a 2020 pandemic response system?
One thing I would add, you know, there's a lot of people at Optum who've been looking at AI and COVID at the start of this crisis smarter than me. But almost at a personal level, one other challenge I think we have with the state of the art of machine learning and AI right now is that in March and April, it was really hard to understand what to learn from. Like, you didn't really feel like you had ground truth. And so a lot of people came to us and said, hey, how can we use AI to address this crisis? And we weren't even sure what problem we were trying to solve. Was it ventilators? Was it treatment? Was it risk? Was it tracing? And so, you know, it just struck me that one of the things we have as a challenge with these technologies is like, when something emergent happens, what do we learn from and how do we learn from it? I am encouraged though, like I think I've only read and I haven't fooled around with it, but there are breakthroughs like GPT-3 from OpenAI, which are starting to really change how much information we need to learn from. You know, they call it one shot or small shot learning. And that's really intriguing to me because I wonder if what happens next, if capabilities like that may help us to adapt and respond even faster in a pandemic level crisis, especially when something emerges quickly and we don't know what the ground truth is to learn from. You know, these unsupervised learning capabilities are probably going to be our next big area of thinking and research because I think they may help in the future.
Then you bring up a good point, although one counterpoint there is, as Dr. Lamka said, a lot of our healthcare today runs on spreadsheets. Right? Yeah. When we talk about, and yes, we can build AI and sophisticated systems, but at the very crux of it, when came time to how many ventilators, hospital bed capacity across 6,000 plus US hospital system, much of that was manual, spreadsheet driven, and people had to update and upload the files twice a day to a central repository. I think there ought to be a better answer. We talk about data interoperability. Where is that standard? Why couldn't we have done it in a, you know, an API way, an automated way? Yes, AI will help, but that collection and for data, I think there's better ways, like as we are in 2020, to collect the data. It should not be that manual and effort. And I think that is a wake-up call today. And we are seeing that the fragility of infrastructure, fragility of our supply chains, it became pretty clear, and we're seeing a lot of good work happening in the industry now to automate some of that.
That makes sense. I think we're coming up at the witching hour here, 1 o'clock. So maybe just throw this last question out, sort of crystal balling, into the future, year or two from now, 3, 4, 5 years from now. Where do we think AI will be? Will it be absolutely routinized into every single aspect of clinical care? Is it going to progress sort of as it has, sort of slowly, with some of the data curation issues getting a little bit better that, John, you were talking about? Or are we going to, as you said earlier, John, the future is here and it's only going to come quicker. So why don't I start with you? You're the local guy, and then we'll hand it to Ashima and Sanji for a minute, and then that'll bring us to 1 o'clock, and we'll have our yogi come in.
Okay, well, so Ashima told us about AI ops. So think for a moment about your phone. You have apps. Why have you downloaded those apps? Oh, because I needed a particularly useful function. I looked at a store, I decided what met my needs, and I decided to use that one. Oh, I don't like that one anymore. I'll go get another one. Oh, here comes a better one. I'll use that one. Well, I think of AI algorithms we're going to have a marketplace. Optum will have AI algorithms. Mayo will have AI algorithms. Google will have AI algorithms. And you're going to see the rise of AI as a service, where a clinician who needs a specific function will, in effect, download an app. I mean, it may not be an app in that respect. It's more likely an API and a service they connect to. But that the industry that is healthcare today is ultimately a data business. And that the healthcare we're delivering today in bricks and mortar will, in the next several years, be more about the algorithms we develop and the specialty knowledge that we encapsulate in the services we're able to distribute to the marketplace.
It's hard to go after Dr. Halamka, but I'll try.
I was going to say. Very cool. Very visionary. But it sounds fairly accurate, too.
Yes, and I think that's where I feel fortunate to get to work with him and so closely from the healthcare perspective, right? As I look into the next few years, we all are seeing the rise in telehealth, virtual care, store and forward health, but still that capability, which patients are ready for telehealth, virtual visit experience versus which need a little bit more hands-on care, all that algorithm and that kind of triaging, I think it will emerge, the intelligent patient triage and the application of AI in determining the right care, the right setting at the right time. I think a lot needs to be developed there. The second is rethinking our revenue cycle, rethinking our back office automation. There's a lot of still human work that goes behind the scenes in working the claims and in the coding, the billing. That area is kind of ripe for, with the help of machines, can we assist? Can we bring that knowledge into the back office, the automation, and rethinking that back end? I think that we'll see a lot of that focus there. And finally, and I hope that any progress that we will make will be driven by people embracing new tools, new ideas. And if anything, pandemic has given us that purpose. And this is the time to expand and extend our capabilities by leveraging any tool that is available to us.
I think Ashima stole my last one because we are driving a lot of that back office stuff. But two things, like it's hard to know what the future holds, but two things that I'm looking out and watching closely are the continued improvements in models and methodologies to explain or derive causality from inference. Explainability, interpretability, I think are going to continue to be more important for all sorts of reasons, especially for clinicians to be confident in what recommendations might look like. And I'm very intrigued to understand like how we see machine learning intersect with graph data, like the representation of healthcare systems and healthcare experiences seems to be very well attuned for graph structures. And I'm sure there are going to be great breakthroughs in the next 5 years that bring both machine learning and graph closer together in a way that may enable all the types of use cases that Ashima and Dr. Lamka described.
Terrific. Thank you, Sanji. Debrel, I'm not sure you take it from here, but I just want to thank John, Ashima, and Sanji for terrific commentary today. I certainly learned something. I hope the audience did. I know we have a lot of questions, and I think we're able to answer those after the session ends here today. So, Debrel, did you want to take it from here, or should I have Stephanie?
Thank you, Chris, and to all of our panelists. If you'd like to continue the conversation, please join us on Twitter. And now, relax and unwind with a short yoga flow led by Stephanie Wallace.
Hi, everyone. Welcome in. Thanks for sticking around for our yoga flow. Wherever you are, let's get started. If you're seated, or perhaps you are kneeling as such. If you're in a chair, that's great as well. But let's just take a moment with the hands face down on the legs to take a deep breath in through the nose. And open mouth, exhale. Good. Wherever you are, stretch your arms up overhead, get long in the sides of the body. And we'll take the left arm down, right arm up and over. So either seated or kneeling, your choice. Try to draw your right shoulder down and back to get an opening in the shoulder and the rib cage. Inhale to come back through center. And exhale to the other side. So right arm down, left arm stretching up and over. Try to root down through your left hip here. But inhale back through center. We'll take that side to side. Left arm down, right arm up and over. Roll the right shoulder down and back. Inhale back through center. Exhale to the other side. Left arm up and over. Maybe you get even deeper into the stretch. Good. Start to come back through center. And we'll do that one more time each side. Left arm down, right arm up and over to stretch. Inhale back through center. And exhale to the other side. Good. Inhale back through center. And let's take it to our tabletop. So roll over onto the hands and knees. Stacking our shoulders over wrists, hips over knees, fingertips spreading out nice and wide. Long line from the tailbone to the crown of the head, so try not to let the belly sink down too much here. On an inhale, we'll intentionally lower the belly, lift the gaze, tailbone, and heart. Exhale to round the spine, press the ground away, hollow out the torso as you tuck your chin. At an inhale to lower the belly, lift the gaze, tailbone, and heart. And exhale to round, moving up and in. Try not to lock out the elbows here. One more time. Inhale, lower the belly, lift the gaze, tailbone, and heart. And exhale to round up and in. Good. I'll encourage you to take a few more deep breaths here. So maybe you keep going back and forth in that linear movement of cow to cat, or maybe you incorporate a little side to side, just feeling out where the body is in this moment before we start to move a little more. Maybe there are some barrel rolls of the torso, a sway side to side. You can play with flipping the wrists or tucking the toes. Anything that feels necessary in your body today. And once you've evened out any movements that you need to, find your way back toward your neutral tabletop. Step your hands just about one palm print in front of you. As we start to tuck your toes, lifting your hips up and back to find your downward facing dog. And right away, let's keep us some movement here. So bending into one knee, straightening out the other. Try to use the breath as you make movement with the legs. So if you feel like the movement is really quick and choppy, can you slow it down to meet your breath and allow the breath to guide you in this moment? Good. Then find some stillness here. Guide your heart back towards your thighs, and maybe there's a soft bend into your knees here, so try not to stress out your hamstrings. And then we'll slowly start to walk your hands back towards your feet for a forward fold at the back of your mat. Keep your feet at least hip-width distance apart here, so that's at least 2 fist width in between your feet. And let your head hang loose, so no tension in the neck. Maybe you sway it side to side, shake it yes and no, a little maybe. And then let's grab opposite elbows here to find a little weight in the torso. Perhaps there's a sway side to side or a shift of the weight from side to side, back and forth onto the toes and the heels. Again, trying not to have any tension in the back of the neck. And then super slowly, we're gonna roll up all the way. Keep that soft bend into your knees. Keep your head heavy as you start to rise all the way up to stand. When you arrive, roll the shoulders down and back, flip the palms to face out and in front of you. Take a big inhale as you stretch the arms up overhead. Exhale to forward fold, slight bend into the knees as you fold. And we'll start to walk your hands forward into a high plank, top of a push-up. Long lines of energy from the heels to the crown of the head. And at any time, knees are available to you as well, but try to keep the torso nice and long, whichever variation that you are in. So if we're holding with the legs activated, try to keep the breath nice and steady and try not to lock out those elbows here. We're gonna shift forward slightly and begin to lower, knees or not, all the way to the belly. Taking your time to come to the belly. Flip the toe side down on the floor. Lift up your heart for a baby cobra. Little to no weight in the hands so that you're really using the upper back muscles to help lift the heart here. So take one more deep breath in. And then lower the forehead down. Hands beneath your shoulders as you shift your hips back towards your heels for a child's pose. Just for a moment here, maybe you rock the forehead from side to side. Gentle massage of the mind's eye, relaxing any thoughts, any lingering expectations here. And slowly start to draw yourself up through a tabletop position. Tuck your toes, lift your hips up and back, downward facing dog. Nice. Inhale to bend your knees and take your gaze forward. Step your right foot to the top of the mat. Left foot follows. Feet can be together or hip width distance. Inhale to lengthen the spine halfway. Draw the shoulder blades back. Reach the heart forward. Exhale to forward fold over the legs. Root to rise. Big breath in as you come all the way up. We'll take your right hand around your left wrist. Press slightly up with the hand and over to stretch the left side of the body. Try to let the shoulders relax down away from the face. Inhale to come back through center. Switch your grip, left hand to the right wrist, and start to stretch over to the opposite side. Beginning to come back through center, big breath in. As you exhale, forward fold over the legs. Inhale to halfway lift, lengthening the spine. Exhale, plant your hands, step your right foot back. Left foot follows. Pausing here for a moment in your high plank, knees or not. Good. Then go ahead wherever you are, take your knees down. We'll shift forward slightly. Just lower right under halfway, so about 90-ish degrees here. Then flip onto the tops of your feet. Press into the legs to find an upward facing dog. Cobra is always there for you as well if that feels better in the body. Good. Drop the knees down, tuck your toes, hips up and back to find downward facing dog. Take a deep breath in through the nose. Full breath out of the mouth. Bend your knees, take your gaze forward. Step your left foot to the top of the mat. Right foot follows. Inhale to lengthen the spine. Exhale to forward fold. Root to rise. Big breath in. Exhale to forward fold over the legs. Inhale to lengthen the spine. Exhale, plant your hands. Step your left foot back this time. Right foot follows and pause in your high plank. So you have the option that we did the first time to lower all the way to the belly. Second option to drop the knees like we just did, or this time we're going to keep the legs lifted if you'd like. Shift forward, lower halfway, chaturanga, pause. Flip onto the tops of the feet to find an upward facing dog. Keeping the knees and thighs lifted here. Option to drop the knees or not. Tuck your toes, lift your hips up and back. Downward facing dog. Good. Let's take a deep breath in. A full breath out. Good. Inhale, bend your knees, take your gaze forward. Option to step or hop to the top of the mat. Forward fold. Inhale, lengthen the spine. Exhale to forward fold. Inhale, root to rise all the way up. And then bring your hands to heart center. So keeping your feet hip width distance apart, or maybe you bring the big toes to touch, your choice. We're gonna bend the knees, drop your hips, find your chair pose. Trying to bring the knees behind the toes here, engaging the inner thighs as well. Almost like you're trying to squeeze the legs together, but not from the knees, right? Arms can be reaching up or hands to heart center. Good, pausing here for a moment, nice deep breaths. Try to take the sway out of the back by drawing the low belly up and in toward the spine. Now option, you can keep the heels grounded or start to lift up the heels a little bit as we lower a little bit more. A little bit lower. Keep going lower. Nice job, you guys. Beautiful control. You come all the way down to a seat on your mat. Great job. So once you find your seat on your mat, extend both legs out and in front of you. You can move the flesh away from the sitting bones to root your seat down into the mat. Legs can have a little micro bend here as well to give a little grace to the hamstrings. Inhale to sweep both arms up overhead. And exhale to fold over the legs. You can reach for behind the calves, behind the knees, bottoms of the feet, whatever is available. Trying not to stress out too much about what we're trying to reach for here. Each inhale, find length in the heart. And each exhale, fold over the legs. So 2 more breaths, just like that. Inhale for length. And exhale to fold. One more time. Inhale to lengthen. And exhale to fold. And slowly start to roll yourself up. We're going to scoot slightly forward. Take the soles of the feet together and your knees out wide for your butterfly pose or Baddha Konasana. Hands can interlace around the feet, or maybe the hands come towards the shins. Inhale to lift from the heart. And as you exhale, fold forward only as far as you can go before your shoulders start to round. So once that starts to happen, can you come back up and find that flat back? And think about sending the hips back as you reach the heart forward. Just 2 more deep breaths here. One more deep inhale. And full exhale. And slowly start to come back up. Use your hands to encourage your knees toward one another. And step your feet out and in front of you slightly. Knees are about shoulder width distance apart here. You can reach for the tops of the knees as you inhale. Heart reaches through, arch the back and look up. Exhale to round the spine and extend it in between the shoulder blades. And inhale, heart reaches through, gaze up. And exhale to round and extend. One more time. Inhale, heart reaches through, gaze up. And exhale to round and extend. This time we're going to come all the way down to the back. So take your time finding your way onto your back. Finding one final pose here together. We're going to take a supported bridge pose. So feet are at hip width distance apart. Fingertips want to be able to tickle your heels here. We're going to press into the hands and feet and just lift up the hips here. Try to take the focus out of the glutes and more on the feet pressing into the floor to lift the hips. Guiding your chin, or your heart rather, back towards your chin, but your chin slightly away here. So keeping that throat open. Go ahead, take one more deep breath in. And then slowly roll down from your upper back to your middle back and your lower back. You can let your knees fall in toward one another and take one deep breath in together. One full breath out. Take both knees into your chest. Give yourself a little hug here. Wrap your arms around your shin. Take one deep breath. And as you exhale, you can relax, coming to lie down just for a moment. And then whenever you're ready, begin to sit yourself back up. You can roll over to one side if that feels necessary to rise up. Find your seat. You can take your hands to heart if that feels right, or maybe just letting your arms relax in your lap. Taking one final breath in together through the nose and relax it all out. Thank you so much for allowing me to guide this practice with you today. Hope you have a wonderful rest of your day and week. Namaste, my friends.
Thank you, Stephanie, and to everyone for joining us today. Have a great rest of your week.